Great, thank you. Terrific to be here. Those were some wonderful radial cases, and before that, a great number of coronary and structural cases. Really enjoying it. These are my disclosures. Relevant to this talk is research funding that goes to Brigham and Women's Hospital. So I'm going to say a few words about Kangal, a drug that's relatively recently approved in the US and Europe. This is an intravenous ADP receptor antagonist, very short onset to action, very short offset of action. Studied most recently in the Champion Phoenix trial, a trial of 11,000 essentially all comers for PCI, stable angina, non-STEMI, and STEMI, the major exclusion criteria being treatment with an oral P2Y12 inhibitor prior to arriving at the cath lab, so patients that had been pre-treated with oral Clopidogrel, Prasugrel, Ticagrelor were excluded, but other than that, really no major exclusion criteria. The primary endpoint was the composite of death, MI, ischemia-driven revascularization, stent thrombosis within 48 hours. And for Kangal versus on-the-table Clopidogrel loading, this primary endpoint was significantly reduced. And this is what led to the FDA approval and the EU approval of the drug. The key secondary endpoint was stent thrombosis, and that too was reduced by about 40 to 50% at 48 hours. The primary bleeding endpoint was gusto-severe bleeding. There was no difference between the two treatment arms. And we looked at a bunch of other bleeding scales. And looking at more sensitive bleeding scales like the acuity scale, there was a significant difference, a significant excess with Kangal versus Clopidogrel. But even looking at things like blood transfusions, there was no significant difference. So really, the difference was in groin hematomas. But other than that, no significant differences in more serious or major forms of bleeding. One question that came up after the initial data had to do with what sort of MIs were being reduced. Of course, there are some out there that debate the value of peri-procedural MI, and that would be another talk. But for those that wondered, we did do a number of sensitivity analyses. These haven't been published yet, of different definitions of myocardial infarction and different endpoints. So looking at the primary endpoint that I just showed you, that was significantly reduced. But then if one removes intraprocedural stent thrombosis and just looks at death, MI, ischemia-driven revascularization, the ARC definition of stent thrombosis, there too there's a significant reduction with Kangal versus Clopidogrel. If there's removal of intraprocedural stent thrombosis from the composite and removal of MIs that are just biochemically defined and instead focusing on death, MI with a CK greater than 10 times the upper limit of normal, or an MI with symptoms or ECG changes, ischemia-driven revascularization or ARC-defined stent thrombosis, there too, there's still a significant reduction. And then just removing everything that is other than a clinical endpoint and examining only death, MI with symptoms or MI with ECG changes, ischemia-driven revascularization, ARC stent thrombosis, still the results remain statistically significant. So with the more specific definitions, the event rates drop, but if anything, the degree of benefit becomes even larger the more precise the definition is. So through a number of other sensitivity analyses, the SKY definition of MI, et cetera, the benefits remain significant. There were two other trials for the sake of time that I won't review, but have been meta-analyzed and published in The Lancet. And overall, it's a pretty consistent message for Kangal versus control, with significant reductions in the endpoint of death MI, ischemia-driven revascularization, stent thrombosis, as I mentioned, with no heterogeneity really among the trials. But if one examines stent thrombosis, again, about a 40 to 50% significant reduction in this pooled data set of about 25,000 patients, looking at quote-unquote harder endpoints, just death MI, ischemia-driven revascularization, or even death Q-wave MI, ischemia-driven revascularization, still significant reductions in this pooled meta-analysis. Leading the editorialist of that meta-analysis, Shamir Mehet, that posit, is Kangal a new champion for percutaneous coronary intervention? So a question that came up after the initial publication of the data is, what about the STEMI patients? And of course, we know there are a lot of issues in STEMI patients, interactions that have been described between morphine and absorption of oral drugs, including oral ADP receptor antagonists. Of course, a proportion of patients with ST elevation might have nausea, emesis, might be in shock, might be hypoperfusing their gut and not absorbing well on that basis. So for a variety of reasons, oral drugs may not be fully absorbed, active, and effective early on after administration in the context of STEMI. And that, in fact, has been studied in Champion Phoenix. It's buried in the appendix of New England Journal, so a lot of people never got to see it. But the overall STEMI results are quite concordant with the overall trial findings with respect to the primary endpoint, with respect to stent thrombosis, even with respect to bleeding. Very similar what was seen in the STEMI populations and the overall trial. And that same pattern holds up in the pooled population, where both the STEMI cohort and the overall trial essentially the same degrees of benefit as well as the same degree of bleeding hazard. But it's a lot of data to go through, so I won't go through it in detail, but instead show this case from Mike Gibson and Dwayne Pinto that they published in Journal of Invasive Cardiology late last year. It's a patient that came in with an ST elevation MI and was pre-treated with 300 milligram tablets of Clopidogrel. So the patient was pre-treated, as many people do, but as you can see, that's where the pre-treatment is. So when we're pre-treating patients with STEMI, oftentimes it's really pre-treatment for the physician more so than the patient. Those pills obviously aren't going to be absorbed or active by the time the PCI is even done in the context of primary PCI for STEMI. Well, what about trying to make oral drugs better? There have been some attempts at that as well. The Mojito study, a well-done trial looking at crushed ticagrelor versus just whole ticagrelor. And as you can see early on, say at the 1 hour time point, greater degrees of platelet inhibition with crushed versus whole swallowed ticagrelor. Ends up not mattering by about 4 hours, but there is a difference with respect to platelet inhibition early on. I should point out, obviously, this is not clinical outcomes. These are mechanistic studies, 82 STEMI patients. So this doesn't really say if this would translate into a difference in clinical events for stent thrombosis. But nevertheless, at least intuitively, it seems like there might be some benefit from crushing. Though, even though it seems kind of like a trivial thing to do, if you were going to crush, you need to make sure you've got the right equipment, that the full quantity of medication is actually taken by the patient, that it's not left sort of clinging to the side of the container in which it's been crushed. So it's not rocket science, but on the other hand, one does need to be careful, or one's nurse needs to be careful in administering it. Otherwise, you may be hurting the patient by giving them crushed ticagrelor because they're getting crushed ticagrelor, but at a lower dose. So I do need to use a little bit of common clinical sense. Another study was the CRUSH study. This examined again, its PD and PK effects of crushing prasugrel, much like Mojito examined crushing ticagrelor, and by a couple of different assessments of inhibition of platelet activity. In both cases, there were significant reductions in platelet activity, that is greater degrees of inhibition, that were significant for the first couple of hours, though by about 4 to 6 hours, it was no difference between crushing or just taking standard oral prasugrel and swallowing. So once again, pharmacokinetic and pharmacodynamic data suggesting faster onset of action. You ultimately get to the same place, but you get there a bit quicker. Though, again, in the context of STEMI, perhaps not quite quick enough, depending on the time to treatment. And what about Kangal then, if one were, in fact, going ahead and giving prasugrel and ticagrelor or crushing them and so forth? So this is an interesting pair of studies looking at patients on maintenance prasugrel and ticagrelor. So they're already on prasugrel and ticagrelor. And in this case, they're getting reloaded with prasugrel and in the experimental arm also getting Kangal. And as you can see, at baseline and at an hour, and even to an extent at 4 hours, still greater platelet inhibition with Kangal, even with that baseline prasugrel on board and a reload. And basically the same story with ticagrelor. This work hasn't been published, it's still in abstract form, but still same theme. That is, even with ticagrelor baseline, reloading, still incremental antiplatelet effect, especially early on. with the Kangal, or even persisting in this study out to 4 hours. So just to conclude about these data, Kangal might be an option in patients who are not pretreated with oral ADP inhibitors. That's a particularly appealing strategy, I think, where there is a short time to treatment, such as in STEMI, and in some centers, even non-STEMI, that goes to the lab quickly. Crushed ticagrelor or prasugrel does kick in earlier, but it's unclear what the clinical benefit is. And even in that setting, Kangal appears to provide incremental antiplatelet effect. Thank you very much for your attention.